Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Akebia Therapeutics, Inc.
Hello, I'm Dr. Susan Hidayati. I am a nephrologist, and I'm delighted to be joined by my colleague, Dr. Volker Haas. So let's start off with a patient case. So this is a case of a 45-year-old woman who has dialysis-dependent CKD secondary to autosomal dominant polycystic kidney disease, and she complains of fatigue and shortness of breath. Her current medications include amlodipine, atorvastatin, B vitamin complex, calcitriol, furosemide, levothyroxine, lisinopril, and sevelamer. On labs, she has a low hemoglobin of 9.5, a hematocrit of 28.9. And as you see on her other labs, her dialysis prescription has resulted in a KT over V of 1.44, which is adequate. Her levels of folate and B12 are also adequate, but she does have labs that indicate um, iron deficiency with a ferritin of 100 and iron saturation of 18%. In addition, she has an absolute reticulocyte count that is low. So, how do we diagnose and evaluate anemia of CKD in dialysis dependent patients such as this? By definition, anemia of CKD is defined as a hemoglobin of less than 13 in men and less than 12 in women. And as you see from this table, because of the prevalence of anemia in our patients, we need to frequently test them and order a hemoglobin and hematocrit at least once a year in patients with CKD stage 3, twice a year in those with CKD stage 4, and then every 3 months in patients with CKD stage 5, whether or not they're dialysis dependent. This graph shows that as GFR decreases, hemoglobin levels also decrease, so that by the time you reach a stage of 3B and your GFR is 30 or below, anemia of CKD becomes very prevalent. Now, anemia is not only prevalent in our patients, but importantly is associated with poor outcomes, not only clinical outcomes such as lower survival, higher risk of MACE or major cardiac adverse cardiac events, more left ventricular hypertrophy, and higher rate of hospitalizations, but also patient centered outcomes such as lower quality of life, more fatigue and lower work productivity, more cognitive decline, and a higher risk of having to receive more blood transfusions, which is very, very burdensome for our patients. This slide shows the regulators of iron metabolism and anemia of CKD. And if you look toward the left lower corner of the slide, you see that in addition to kidney failure, which results in decreased erythropoiesis, factors such as inflammation and uremic inhibitors suppress the bone marrow to produce red blood cells. In addition, if you look at the right upper corner, decreased renal clearance and inflammation lead to elevated levels of hepcidin, which results in decreased iron uptake from the gut and decreased mobilization of iron stores from both the liver and the spleen, resulting in lower circulating iron transferring complexes. In addition, in our patients, blood loss, either from the dialysis procedure or from GI losses, can contribute obviously to reduced number of circulating red blood cells, as well as lower iron transferring complexes. So now that we've learned a little bit about the epidemiology of anemia of CKD, let's turn to management. Before we start, in a patient that presents with anemia in the setting of dialysis-dependent CKD, it's very important to address other correctable causes of anemia, which include, as we spoke about, blood loss, hemolysis, folate and B12 deficiency, dialysis inadequacy, as well as inflammation due to underlying malignancy or infection. Now, one of the most important factors in anemia of dialysis dependent CKD is, of course, iron deficiency. And we define that differently in our patient population because, in general, there are higher levels of inflammation in our patients, so that ferritin levels are usually elevated. So that we would like to replete iron if a ferritin level is less or equal to 500 nanograms per ml and a TSAT is less than or equal to 30%. We also recommend treating them with IV rather than oral iron supplementation, given patient preferences and need to replete the iron quickly in order for them to start to retic once they receive a erythropoiesis stimulating agent or ESA. Now, the threshold for initiation of ESAs is usually a hemoglobin of 9 to 10 grams per deciliter based on the patient's risk profile and preferences. So, in patients who have a low cardiovascular risk but have symptoms from anemia and maybe kidney transplant candidates, we may want to target starting at a higher hemoglobin level. But in those who have greater risk of cardiovascular events, we may want to not start an ESA until they become symptomatic or the hemoglobin level drifts to 9. The target hemoglobin that we would like to maintain is recommended to be between 10 and 11.5. These are KDIGO recommendations shown in the right panel of the slide. There are other non guideline based iron status parameters, such as percent tachychromic red cells and reticulocyte hemoglobin content that are being further investigated. So then, based on this patient, the way we would treat based on her labs is to make sure that we supplement her with IV iron therapy. And once we have repleted her iron stores, then if her anemia persists and based on her comorbidities and risk factors, we can contemplate the initiation of ESA. So, Volker, tell us a little bit about your thoughts about ESAs.
Yeah, thanks, Susan, for asking this question. So obviously, so this patient has already very advanced kidney diseases in a dialysis patient. So she has relative EPO deficiency, and the other arm of the treatment strategy is to replace EPO with recombinant EPO. The bone marrow needs EPO, or erythroid precursors need EPO to stay alive, so to speak. As you know, EPO has certain risks, certainly benefits in terms of improving hemoglobin levels, and also probably some, although this is people may argue about the studies, quality of life. But I mean, it will definitely help with the dependence on transfusions, so it will reduce blood transfusions. And as you know, also studies have shown a reduction in left ventricular hypertrophy. But there are risks, thrombotic events, hypertension, access thrombosis, so risk for cardiovascular events.
Thank you, Volker, for pointing out the benefits and the risk of ESA. Maybe tell us a little bit more about the preparations for ESAs.
Yeah, so um, these are preparations that consist of recombinant erythropoietin with different modifications to the protein, and they have different half lives. So In our part of the world, erythropoietin alpha is very common. This has a very short half life. It's given usually 3 times a week. Um, Typically with through the IV route. There's a longer acting erythropoietin, a more differentially glycosylated erythropoietin that is called darbepoetin alpha. As you can see by the administration schedule, I mean, this can be given weekly or every 2 weeks. And then there is a erythropoietin preparation with even longer half-life, pegylated form of erythropoietin, sera, which is the continuous EPO receptor activator. So it binds to the EPO receptor longer, so it has the longest half-life of all the three of them. So EPO alpha about 8 hours, darbepoetin about 3 times, and longer, and sera about 130 hours or so, 130, 140 hours or so. So it depends a little bit on the preferences of the different dialysis units, what they give. But as you can see from the table, so we have 3 times weekly versus once every week or 2 weeks versus every 2 weeks. So now, since we sort of discussed a little bit the different preparations of recombinant erythropoietin, so I just want to come back to your when you were talking about the hemoglobin targets, how we treat our patients. So how did this actually evolve? I mean, how did we end up with these hemoglobin targets of 10 to 11? And maybe you can talk a little bit more about the risks that are associated with ESA therapy.
Yes, of course. So, we had mentioned before that anemia of CKD, especially in dialysis dependent patients, is associated with bad outcomes, not only death, but major adverse cardiovascular events. But, to this day, we don't have a trial that shows that treating patients to normalize their hemoglobin or treating them with an ESA actually reverses that risk. So we don't have any definitive evidence, any definitive and consistent evidence to say that ESAs or a high hemoglobin target actually has a mortality or cardiovascular benefit. In fact, as you see from this slide, the TREAT trial, which was one of the largest trials, placebo controlled trials that was done using ESAs in patients with chronic kidney disease. This trial was done in over 4,000 patients with type 2 diabetes who were randomized to darbepoetin alpha to achieve a normal hemoglobin of 13 versus placebo. Uh, didn't show a treatment benefit for the primary cardiovascular composite outcome. Now, these patients, the patients who were on placebo, were rescued with Darby if their hemoglobin did drift below 9. So not only did this trial not show a benefit as far as cardiovascular events or outcomes, but also as a secondary outcome, there was a risk of harm, so that the risk of stroke almost was double in the Darby arm as compared to the placebo arm. So, based on this and other studies, this is the way we had come up with the recommendations for using that target of less than 11.5 uh, for patients who are being treated with ESAs and are dialysis dependent. So, Volker, can you share with us a case where alternatives to ESA therapy may be needed in patients who have dialysis dependent CKD and anemia?
Absolutely. Let's just dive into this case here. So this is a different patient now. So this is somebody. It's a 50-year-old man who feels sluggish throughout the day and needs to rest after exertion, and he has been on dialysis for about a year or so. Has a typical history that we see. He's already being treated with erythropoietin alpha, so he gets this 3 times a week, 7,400 units. per session. So that's a quite a high dose. He's getting also IV iron, and then he gets his cardiovascular medication. So now he's getting 7,400 units of erythropoietin. Has already undergone some dose escalation. These are the labs of this patient. So if you look at his red cell blood count is low. His hematocrit is 25.8. 8.5 is the hemoglobin. The MCV is low normal, 87, but the hemoglobin concentrations of the red cells indicate that there is some problem with iron handling. And you can see that his ferritin is quite high, 750 with a T-set of 27. So just about target range, but we like to keep it a little bit higher than that. So just below 30%. And the absolute reticulocyte count for this degree of anemia is very low. Um, Hemodialysis is adequate. KTOV is 1.56. And then as you can see, I mean, he's on dialysis, so that these values don't really mean so much on a patient that is actively on dialysis. So I said already that dose of 7,400 EPO times 3, so 21,000 units per week in a patient that is about 70 kilograms in this case, that is sort of already indicative of hyperresponse. So this is a patient, he had undergone several increases in EPO dosing already. And when you look at the definitions, how we define hyperresponsiveness, there are different ways to do it. When you go by the dose-based definitions, so he's getting more than 300 units per kilogram per week. So this is the definition from the UK Renal Association, British Renal Association. And then if you look at the KDIGO, this is the 2012 definition, um, uh, which basically says that they differentiate between an initial resistance and then a resistance that develops while the patient is on dialysis. So no increase in hemoglobin level from baseline after the first month, or with an appropriate weight-based dosing would give you the diagnosis of hyperresponsiveness. And then when you're already on dialysis, when the patient is already on dialysis, if you have, it's a bit an odd formulation in this case, but if you had two increases in EPO dosing, about 50% or so beyond the dose at which the patient was stable, hemoglobin was stable, that also qualifies you or puts you into the category of hyperresponsiveness. What does hyperresponsiveness mean? I mean, it has actually clinical implications. So people who are poorly responding to ESAs have a higher risk of morbidity and mortality. And you can see here in this graph that the survival of patients with poor response is reduced. So it's not just something that we do for diagnostic fun. We diagnose somebody with hyperresponsiveness. This actually has a clinical implication, and the implication is that those patients usually do less well in terms of survival, in terms of cardiovascular risk. What are the mechanisms of hyperresponsiveness? So obviously the list is long here. I would point out that inflammation is a major cause of hyperresponsiveness, and usually hyperresponsiveness is transient. So infections, dialysis catheter use by per se is increasing inflammation. And these is a list of some of the potential causes of hyperresponsiveness, and about 30% are unexplained. Some of it is related to malignancy. So if you have somebody with hyperresponsiveness, you need to think about potentially cancer, GI cancer. You need to look at infections. You need to rule out that they are adequately dialyzed and that they don't have hyperparathyroidism.
So in this case of ESA hyporesponsiveness, what is the best next step? Would you use HIF-PHIs in this case?
Yeah, that's a excellent question. So obviously, he's already at a level of EPO dosing where we would not recommend a further increase. So the HIF-PHIs are a new class of medications. They are oral medications, so they don't require an injection, a parenteral administration. They're oral, and they mimic the body's or the tissue's response to hypoxia. So what they do is they activate a transcription factor that is called hypoxia-inducible factor, and this factor is normally active when the tissue or cells experience hypoxia, when the kidney experience anemia. So anemia is another form of hypoxia, and this is when this factor gets activated. And the body only activates this factor when there is a lack of oxygen. So when oxygen is present, these prolyl hydroxylases, or these PhD enzymes shown here, there's 3 of them, they they uh, facilitate, or they initiate the degradation of the oxygen sensitive subunit of this transcription factor. So it's transcription factor 2 units, subunits alpha and beta, and one of the subunits is alpha is oxygen sensitive. It's regulated by these PhDs, and they promote or facilitate or initiate the degradation of this alpha subunit. So the body makes it all the time, makes alpha, HIF alpha all the time, and then in the presence of oxygens, the enzymes initiate the degradation. And when there is hypoxia, these enzymes are less active. And when you give a compound that mimics one of the substrates of these enzymes, oxyglutarate, then these enzymes are also inhibited. And basically, the HIF-PHIs are compounds that or drugs that reversibly inhibit these enzymes that normally promote or initiate the degradation of HIF alpha. So as a result, HIF alpha is stabilized and forms a transcription factor with HIF beta in the nucleus, and then activates a lot of different genes, including EPO and including genes that encode proteins that are important for iron uptake, iron transport, and iron utilization. So as you can see from this study by Provenzano et al., HIF, in this case, HIF2, it turns out there are several HIFs, and HIF2 is the one that actually increases or regulates EPO erythropoietin production. So HIF2 activation increases the production of EPO in the kidney and the liver. And you can see that for patients that either receive EPO or receive a HIF-PHI, in this case roxadustat. So this is not approved in the United States. There's only one that is approved in the United States at the moment for treatment of dialysis on dialysis patients, Vadadustat. As you can see, with these drugs generate relatively low EPO levels compared to recombinant EPO. And these are doses that are effective in increasing hemoglobin. So this is one of the mechanisms of action for HIF-PHIs. So they stabilize HIF, they activate HIF, HIF induces erythropoietin. And as I mentioned, the other mechanism of action is that HIF-PHIs stimulate the production of transferrin, increase the total iron binding capacity, have some positive effects on iron utilization. This has been shown in several studies now, and this is why HIF-PHIs work. So they induce the production of EPO, erythropoietin, and they have some beneficial effects on iron metabolism. So we are looking at vadadustat. This is, as I said, this is a medication, a drug that has been approved for patients on maintenance dialysis here in the United States. And this shows these graphs show that this drug vadadustat is effective in maintaining hemoglobin in patients that were initiated on dialysis, so in incident DDD, CKD, and also in patients on maintenance hemodialysis. As I said, this drug currently is only approved for patients on maintenance dialysis, so patients that have been on dialysis for at least 4 months. So that's the FDA label. Um, and the drug is also effective, obviously, not just in hemodialysis patients, but also in patients receiving peritoneal dialysis, as you can see here in this study, with a very balanced um, cardiovascular risk based on the MACE analysis. So when it comes to cardiovascular risk with HIF-PHI treatment compared to treatment with ESA in dialysis. Here we have two studies. So vadadustat and the protostat. The protostat is another agent, was approved in the United States, but is no longer marketed. When you look at the cardiovascular risk, there's essentially a equal cardiovascular risk for ESAs and for the HIF-PHI. There's no difference in the um, hazard ratio, very little difference in the hazard ratio between ESA and the protostat and ESA and vadadustat, darbepoetin in the case of the vadadustat and the mixture of uh, EPO alpha and in the protostat. So, just summarizing some of the safety data regarding HIF-PHI use, there is some safety concern with regard to patients that are not on dialysis. This is why the FDA approved the drug in the United States only for patients on dialysis. Other regions, other countries have approved the HIF-PHIs, various different HIF-PHIs for patients that are not getting dialysis, that are pre-dialysis. So just to summarize the safety data for the HIF-PHIs in terms of cardiovascular outcomes. So in terms of stroke, in terms of the risk for myocardial infarction, in terms of overall cardiovascular mortality, the HIF-PHIs are not worse than ESAs or are not better than ESAs. So they have met non-inferiority criteria for the major adverse cardiovascular event safety trials. These patients do have, however, an increased risk for thrombotic events, and this is stated in the label. And I think you have to be careful with the hemoglobin target. So the same hemoglobin target recommendations apply to HIF-PHIs. Not to go over 11 or 11.5. And there is specific prescribing information that makes these points and warnings that warns the practitioner for increased risk of death, MI, stroke, and vascular access thrombosis.
Thank you, Volker. So it sounds like the HIF-PHIs are a new option with a novel mechanism of action for treatment of anemia in patients who have dialysis-dependent CKD. Uh, the main thing is that the oral dosing of this class of agents provides a more convenient route of administrations for patients who prefer an oral uh, administration route rather than an IV route, especially in patients, for example, who may be receiving home dialysis or who are on peritoneal dialysis. Um, I guess my concern is based on what you were saying also that the long-term safety data are insufficient, so that HIF-PHIs should be avoided if there's increased risk of adverse events, as you mentioned, and they're not the first line therapy if ESAs or HIF-PHIs are being considered in our patient population. Of course, there are groups of patients, as you mentioned, with ESA um, hyposensitivity that may qualify for these medications, as well as those who may prefer an oral route. So, thank you, Volker, for this great discussion, and thanks everybody for your attention. Please continue on to answer the questions that follow and complete the evaluation. Thank you.